Okay, so I'm Dr. Kibe, and I'm going to give a little presentation here on vision and understanding your prescription. So to start here, let's see if I can get this to work. There we go. So to start, I'm going to go over some eye anatomy and optics. So light has to focus on a single point on the retina to have clear vision, and we call that point the focal point. So there are three structures responsible for focusing light on the retina. First, light passes through the tear film, then through the cornea, and then through the crystalline lens. So the cornea is kind of like the window to the eye. It's that first structure that light passes through, and it's responsible for focusing about 80% of the light that enters your eye. And then the crystalline lens is the next structure, and that sits right behind the iris, the colored part of your eye, and that can actually change shape to allow us to focus. And there's a muscle back there that controls that lens called the ciliary muscle. And it is attached to the lens, changes shape depending on where we're looking. And that's responsible for focusing about 20% of that light onto the back of the eye and the retina. And so refractive error is kind of a term we use to describe when the focal point is not landing directly on the retina and is causing us to have blurred vision. So that comes in the form of myopia, hyperopia, and astigmatism. They're all forms of refractive error that can be corrected with glasses, contact lenses, or refractive surgeries like LASIK. So nearsighted, if you're nearsighted, that means you're myopic, you have myopia. And that's difficulty seeing distant objects. So oftentimes near objects are in focus at a certain point. The image is actually focusing in front of the retina in this case, and this occurs because either the eye is too long or the refractive structures are too strong, causing the focal point to land in front of the retina instead of directly on the retina. And this causes us to have blurred vision. So when a nearsighted person is looking up close, the focal point actually does hit the retina because they're looking at something near, and they're looking far away. It focuses in front of the retina, causing that blur. So what do we do to help this? We prescribe minus lenses, and that brings that image back and focused onto the retina directly. So we're actually weakening the strength of the eye a little bit. So nearsightedness, again, is correctable with glasses and contacts. We do get concerned, though, if you have high myopia. So high myopia is considered anything over a -6 in prescription. The majority of nearsightedness actually comes from the eye being too long and elongating. So when you're a kid, every year, if you're nearsighted and you're getting new glasses every year because your eye keeps growing and elongating and stretching, this actually causes the retina and certain structures to be a little weaker in the eye. And it puts us at an increased risk for developing cataracts, glaucoma, retinal tears, retinal detachments, and myopic degeneration. So we eye doctors love to dilate our high myopes because we like to make sure none of this is occurring in your eyes. So those yearly exams can be pretty important for that. And that brings me to my next little topic here is myopia control for kids, for children. So we found that, nearsightedness is caused by genetic factors, but it's also caused by some environmental factors. So being on the computer a lot more like we're seeing a rise in nearsightedness in children. And to mitigate this myopia progression and hopefully prevent them from developing eye complications down the road, there are things we can do to kind of slow down that progression of myopia. So Dr. Harsh actually did a really good presentation on the subject, actually, and the different ways in which we slow down myopia in children, including contact lenses. There's some eye drops that work as well. So if you have a kiddo at home that's really nearsighted, that's something to consider because it does help us decrease these complications later in life. So that brings us to farsightedness or hyperopia. So if you're farsighted, that means you have difficulty seeing near objects more. So what's happening is the image is actually focusing behind the retina. So the eye is too short or the refractive structures are a little too weak. We prescribe plus lenses or magnifying lenses to bring that image up to the retina. As you can see in that bottom picture there, it kind of helps strengthen the eye so we can see. So the crystalline lens actually plays a factor into people who are farsighted or have hyperopia. So the lens in the back of the eye, again, has those muscles that kind of flex and cause that change shape of the lens and focus light onto the retina. So it kind of works like a camera lens changes shape and focuses onto the retina. So the closer you hold something to the eye, the more you have to engage the muscle and lens to focus on that specific object. So someone who has mild hyperopia may be able to overcome it without needing glasses because the crystalline lens can compensate for some refractive error. That's if it's mild. Now, how these people get in trouble is that you are more at risk of experiencing eye fatigue or headaches if you have mild hyperopia and you're not wearing glasses for it. So they're more likely to have frontal headaches above the eyebrow or just experience eye fatigue because they have to work those lenses, the lens in their eye and the muscles in their eye to see far away. And then they really have to work them to see up close more than the average person. So they're more likely to experience that eye fatigue and headaches. Again, this is correctable with glasses, contacts, refractive surgeries, and oftentimes at the very least, we try to do reading glasses to take that strain off of you when you're focusing up close. So people can compensate a little bit for their farsightedness with that crystalline lens in the eye, but it leads to a lot of eye strain and issues. So astigmatism. So this is not a disease. This is just a condition, and it is correctable with contacts glasses. So it basically means that you have an irregularly shaped corneal or lens that's preventing you from focusing properly on the retina. So the structures within the eye are not perfectly round in this case, they're a little bit warped. So you've heard the analogy, your eye's not round like a basketball, it's more round, it's more shaped like a football. And this causes the light to bend differently and unevenly and causes that blur. And what's really happening too is that you have more than one focal point that's landing in the back of the eye. So some of it's in front of the eye, some of it's behind the retina. And so with astigmatism, we have to correct all of those focal points. And you can see vision that results in the vision being blurred at all distances. So down here in the corner, we have that astigmatism, how it's kind of bending those lights and streaking the lights in a certain way. It oftentimes does affect people a little more when they're trying to look at distance objects. So there's two types of astigmatism. Some of it comes from the cornea, some from the lens. So most of us have some unevenness in the cornea, which can cause the vision to be distorted. This can change throughout your life. We can measure this unevenness with a machine called a corneal topographer, which is shown on the right here, that colorful image. So this is kind of similar to a topography map of a mountain. You have where it shows the steeper portions and the flatter portions. Astigmatism typically shows up in kind of like a bow tie shape on the cornea on these topography maps. So the red area that's kind of vertical is the steeper part of the cornea, and the blues are on the flatter part of the cornea. So we can see exactly how the elevation is presented and how it's oriented on the cornea. So when you're looking at the image below, you can see this person's cornea is steeper on the 90th degree axis, and then it's flatter on the 180 degree axis. And so that's kind of how we figure out part of your prescription for glasses and contact lenses, by the shape of the front of the eye. There's also lenticular astigmatism. So that's the shape of the lens inside the eye, the other refractive structure in the eye. And so this also can change over time. In the adolescent years, when we're under more visual strain, we can have changes in astigmatism, and then again later when we're older and the lens starts to stiffen and we start to develop cataracts. So when measuring for astigmatism during refraction, the better 1 or 2 tests, we're looking for both corneal and lenticular astigmatism at the same time. So we are accounting for both of those. And astigmatism, so it is not linked, so it can be linked to corneal disease. If we see that you're having high amounts of astigmatism or that it's changing from year to year drastically, we do kind of like to screen you for certain conditions such as keratoconus. So keratoconus is when the surface of the cornea bulges out into the shape of a cone. That's due to thinning in the cornea. So it's actually an issue with your cornea. And so as you can see on the pictures on the left there, that person has keratoconus, and the topography on the bottom right there is that topography that kind of matches. And then pellucid marginal degeneration is thinning of the cornea inferiorly, and it kind of gives a kissing doves image on the topography, or like the crab claw looking. It's kind of how we describe it. And then a normal cornea just has normal astigmatism in a little bow tie pattern there. So there are procedures that can help stabilize these conditions if we do see them, and then specialty contacts if not, to kind of help optimize vision, because people with these conditions do have high amounts of astigmatism. So on to presbyopia. So presbyopia is actually Latin for old vision or old eyes. So this is just the loss of the eye's ability to focus on near objects as you age. The crystalline lens is actually losing its flexibility. So this is when people are in their mid-40s typically and wish their arms were longer. They start moving things away from them because they are having trouble focusing, and that lens just is not quite doing its job anymore. And so we actually add plus lenses to help focus things at near. So they need more power, basically. And we can correct that with glasses or contacts. So there's always the reading glasses, whether they're over the counter or prescription. There's bifocals if you need help with distance and near, and the progressive lenses as well, or the no-line bifocals. So multifocal contacts and monovision contacts are also an option. So multifocal contacts give us multiple points of vision in one contact lens. And I've had a lot of success with them, with people starting to have these issues. They did just come out with a multifocal toric contact lens, which is to correct the astigmatism. And that has worked fairly well, and they are new. So if you were told you couldn't wear multifocal contacts because you had astigmatism, that's not necessarily the case anymore. And then we also have monovision contacts, and that's where we set one eye for distance and one eye for near. It does take some getting used to, and it does mess with your depth perception a little bit. So we always prefer to try the multifocal contacts first, but sometimes we will go to monovision because sometimes people really like that. So some glasses here. Hopefully you're not like this guy on the right that has like 10 different pair of glasses. If you are, you need to come see us. But so we have single vision glasses, we have distance computer reading, and we can really tailor that to any distance you need. I have had some patients who do a trade like glass blowing, and they, need a specific distance, and we can work that out if you need that. They do make over-the-counter reading glasses. Prescription reading glasses can be more tailored to your needs and prescription and give you the best vision. So for example, if you have some astigmatism, we'll add that in. Or if one eye is weaker, you know, we can kind of balance the two eyes with prescription reading glasses. Then the bifocal glasses, that gives you the two zones of vision. You have distance on the top and then near on the bottom. And trifocal, we're adding that intermediate zone. So you have distance and then that intermediate, like for computer or the dashboard when you're driving, and then near on the bottom. And then progressives, or the no line bifocal, they get progressively stronger as you work your way down the lens. So most zones of clear vision in one lens is what the progressive kind of offers. And we tend to choose a progressive lens based on your needs. So if you work on the computer more, we choose a progressive that's more tailored towards that. Or if you're an outdoorsman, we choose a progressive that works better for that. So, and we also have computer progressives too, if you're on the computer, that they're just calibrated for like the computer area and then at near. So it just depends on what your needs are. We like to talk it over with you to make sure we are getting the best option. And then, so let's go through the glasses prescriptions here. So here we have an example of a glasses prescription. Typically you have the right eye and the left eye on here, OD and OS. And then the next column over is your sphere. Then that tells us whether you are nearsighted or farsighted. So myopic people who are nearsighted have a minus in front of their prescription. And then farsighted people who are hyperopic have a plus. And the higher the number, the more nearsighted or farsighted you are. So the stronger the lens you need. And then when we come over to the next two, we have astigmatism. So we have the cylinder, which tells us the amount of astigmatism, and the axis, which tells us the orientation of that astigmatism. So if you remember the topography map, the first column is showing us the difference in the two meridians. The larger the difference between the steep and the flat portion, the higher the number and the more astigmatism you have. And then that axis just shows us the orientation of that irregularity. And then the next column is the add. So that's where you have the bifocal portion. So that's where we give you that magnification at near to compensate for that crystalline lens not working so well. And we have plus to magnify things at near. And then the last, we have prism. So we rarely use this. This is more for people who are experiencing double vision or issues properly focusing their eyes. So that's just to kind of correct eye misalignment. And so we will occasionally do that if someone is having trouble with their eyes working together. And so then we have a contact lens prescription. So glasses RX is not the same as a contact lens RX most of the time. There can be multiple reasons for this, but one reason is that the distance that the correction is from your eye is different with glasses versus contacts. So glasses sit about 1/2 inch out in front of your eye, right? Where the contact lens sits directly on your eye. So we call this distance difference the vertex distance. So the stronger your prescription, the more we have to account for this change between the two. So someone who's a -6 might need a lesser prescription in contact lenses to balance out, account for that change. Another reason is that with glasses, we can prescribe astigmatism down to the quarter diopter and the 1 degree axis, whereas contact lenses, we can't do that so much. They go every 1/2 a diopter and they go every 10 degrees. So you can see in this example here, if this is the same person, the right eye, we went from a -150 to a -125. We had to go down a little bit because they only make them every 1/2 diopter. They don't make it in a -150. And then in the left eye, the axis, instead of 158, we had to go to 160 because they don't make them in 1 degree increments. So that's why there's some differences. And for the add portion, this person's in a +250 add, and we're doing a multifocal. So we fit specific to the brand. So we have the ultra toric for presbyopia for this patient, and we're doing a high add because they need the extra help at near. And the other thing we always do we refract over top of the contacts that you're wearing to make sure that we are giving you the best vision. So even though we pick a contact lens based on your glasses prescription as a starting point, that's not necessarily where we always end. Sometimes we go up or down depending on what we're finding. So thanks so much.